Hello, my name is Dennis Ugren. I'm a professor of child psychiatry at Queen Mary, University of London. I'm a co-director of the Youth Resilience Unit. My other co-director, Jennifer Lau, is actually here as well with us. So I'd like to welcome everybody to this talk. I'm very glad to say that we have a great number of people interested in this from many different countries. I've counted at least 5 or 6 different countries, including not just the UK, but also South Africa, Croatia, the US, and one or two other, Portugal. Wonderful coverage across the world. So I just wanted to introduce Professor Bennett Leventhal. He's a great colleague and a friend of Youth Resilience Unit here in the UK. He's one of the most senior clinicians and researchers in the US. He's got one of the widest span of interests of any research I've come across, really ranging from putting together training programs for junior colleagues all the way to molecular genetics, and something that really that sort of goes well beyond my pay grade. Bennett was especially helpful with us when we were setting up our cohort, which I wanted to specifically mention today. Our unit started a cohort of primary age children in East London. I think it's the first of its kind in a very deprived and diverse area of the world. We've made a very good start, Bennett. You'll be glad to know. I think we've tested well over 100 children now, I think closer to 200. Daniela is actually nodding. He's one of the key researchers on this study, and Milena is one of his colleagues. So yeah, Bennett was exceptionally helpful in actually setting it up, in thinking about the measures and the ages of children. And I think it's been helpful in so many different ways to so many different people in so many different countries that it is a wonderful experience to have him. Just using this opportunity, if any of you are from East London, broadly defined, and you're still interested in joining our cohort, then we are always interested in collaborating with schools. What your children will get would be very thorough assessments, including sort of clinical and research, and you will get to know really well what their mental health is like, and we will follow them for a little while to see how they develop and what predicts resilience in this very interesting group. So without further ado, I'd like to hand you over to Bennett. I'm really glad to see you, Bennett, and over to you. Oh yeah, sorry, and as you know, we are recording, so if anybody is against that, please let me know.
Good afternoon in London. Can you hear me? Okay, great. I actually flew to New York overnight last night so I'd be on a better time zone to give this talk. Not really, so I'm going to try to talk about ASD in the classroom. I'm going to go through some basic information, and then I'm going to offer you some ideas and suggestions. If I'm not hitting the target you like, then tell me and I'll make some changes. These are just disclosures. I work at the Child Mind Institute in New York, and I have funding from the NIH. And I'm also involved in a program called Ascent Autism, which is an online service in California. So we're talking about autism spectrum disorder, which is one of the neurodevelopmental disorders. I think it's really important for us to keep in mind. I'm going to take a few minutes just to remind us what NDDs are, and in particular autism, so that we are at least speaking from the same language. These are syndromes with early onset, most likely prenatal or very, very early in childhood. Almost all of them are a direct result of some identifiable non-specific change in brain function, and the causes of these things are not known, but they appear to be quite genetic, maybe run in families, but also many of these are de novo, that is, spontaneous genetic events. This is a very important point. ASD is a syndrome, which is a group of symptoms that tend to cluster together and share a common natural history. It's not a disease because we don't know the specific cause and or the pathology that causes it. But what this really means for us is that not everybody is the same. People share symptoms. All symptoms don't appear in all patients, and many symptoms are shared across other syndromes. And these are like many other medical conditions, but it has a powerful implication for treatment, which I will say again and again, or the interventions that we're going to use in clinical settings and in schools are largely symptom driven and not specifically autism driven. And I'll keep saying that again. And the other point I'm going to make, and I'll show you some data, that comorbidity, that is coexisting conditions, are very common. These are the DSM-5 diagnostic criteria. They're very similar to the ICD criteria, but there are two main criteria. One is social interaction deficits across contexts, and a set of unusual behaviors, restricted repetitive behaviors. And it all begins early in childhood. But in another way to think about it is that people with ASD often have developmental delays, is things don't occur on time, but they also have developmental deviations. That is, things occur in people with ASD that don't occur in typically developing children. And these can cover a bunch of domains, but generally are focused on social development with things related to joint attention, social reciprocity, and having a theory of mind, being able to think about what someone else thinks, and communication problems of a whole variety, and some restricted and repetitive behaviors. And most people get better over time, by the way. Some symptoms decrease, the repetitive behaviors decrease. They learn to look at people to gain visual information. But the problems of social reciprocity are the most difficult, and language problems are very difficult, and they may persist over time. Now, people talk about autism spectrum disorder, but I think it's an important concept, and everybody says, "Oh, I'm on the spectrum," or "They're on the spectrum." But the fact is, there are many spectra. It's not just one. So, it's the presence or absence of comorbidity, the presence or absence of good social skills, fluent or non-fluent language, or the absence of language, attentional problems, learning problems, problems in behavior. And so when someone says they're on the spectrum, it is not really helpful to us, because it was just like telling you the score of the football game last night was 7. You don't know what it really means. So you have to say what spectrum, what dimensions are affected, and to what extent, before we can think about how we do interventions. ASD is common. This is our paper from 2011, which has now been replicated. Somewhere between 2 and 3.5% of the population is affected. And it's not just because we've changed the diagnostic criteria, just it was the way we collected samples prior to 2010. And we now know if you go into classrooms, you go into schools, you go into communities, that you find about 2.5 to 3% of people involved, which means every classroom is likely to have a child, roughly, or every classroom of 30 to 40 children is likely to have at least one child with ASD, which means we have to pay attention to it. Okay, and this is just a more recent data from the CDC, and the numbers keep coming back roughly the same. Males tend to be more affected, so about 3.5 or something like that percent of males, 2% to females. But the point is, it's a common disorder, and it's clearly a disorder of the brain and brain functions related to language and repetitive behaviors. There are imaging studies that suggest sites for this, but the pathways haven't been well mapped. And it's highly genetic. This is a study that's looking at heritability. It's the most heritable of all medical conditions. So that at least we know of today, with 92% heritability, which means environmental factors account for only 8%. So environmental factors are very rare and are largely powerful toxic events that happen. You folks are familiar with Wakefield and his MMR. So one environmental event is not MMR vaccine. In fact, MMR vaccine, because it protects the brain, and people who have measles often end up with brain injury, the MMR is protective, not causal. And there are many other things that have been suggested, ranging from vitamin deficits to dietary influences, food allergies, brain allergies, metal intoxications, et cetera. Most of these have not held up, although there's some data on very significant metal intoxications causing, and it may be that there's some drug exposures and other things, but they're relatively rare. The most common likely cause is genetic. I told you that comorbidity was common. This is looking at one study of rates of comorbidity. Now, I think it's important that you understand that the base rate of these disorders is high as well. ADHD is roughly 8% of the population, but this is 3.5 times as much in people with ASD. Anxiety disorders are more common, slightly more common. Sleep disorders are more common, et cetera. Depression is about the same, but the suicidality is not uncommon in individuals with ASD. So these are things we have to look for and pay attention to. And when we think about interventions, we may be having to think about interventions that are really overlap other disorders. And that is particularly true in the classroom. And we have to remember that children with ASD become adults with ASD. Who tend to live normal lifespans. Most end up living in their communities and not in institutional settings, but they have all kinds of challenges with respect to education and jobs, which means that our job in the school setting is really important. If we can set them up with vocational skills and set them up with educational language and adaptive skills so that they can function in the community, they're much more likely to be successful. So what we do in schools is really important. When we do assessments, we can do all kinds of instruments, and I'll talk about it in a minute, but I think it's really critical for us to come to understand the individual child and recognize that children with ASD are not unlike many other children, and at least in terms of the fact that they have likes and dislikes. There are things that they like to eat. There are things they like to do. They have sense of humor. It may be an odd sense of humor, but they have a sense of humor. Most of them are interested in having social function. They just don't know how to do it. And when we do assessments, there's a general tendency to be deficit oriented, to try to find what's wrong. What are the problems for the child? But remember that chart I showed you a while ago about dimensions or a part of the spectrum. It's really critical for us to think about what are the strengths that the child brings to the setting, because more often than not, we're going to build on strengths and try to work around deficits. And then we need to understand the child's environment. Where do they live? What does the community think about them? What access to the community do they have? And to what extent can their families manage them, have resources, and can they be included in community activities? And let me give you an example of that where it made a big difference. I used to live in Chicago, and there was a large Catholic community, and the churches wouldn't let the children with ASD have their first communion because they thought they didn't understand, the meaning of communion. Well, how many 6 or 7-year-olds really understand the meaning of communion in the first place? But secondly, the real reason for objecting was the behavioral problems that might be associated. They'd make noise in church, et cetera. So we went to the Archdiocese in Chicago and met with the cardinal and then a group of bishops and priests, and we created a training program for priests so that they could now help these families include their children with autism in their rituals that were so important and traditions that were so important to their families. And we can do the same thing in schools. While the kids may have difficulty adapting initially, with a little bit of work, we can have them participate in choir and in plays and athletics. Okay, they may not be the stars, but the point is that in school, we want children to try and be engaged, and we can modify the environment to make these things happen. Later, I'll tell you a story about that. So to identify all these things about children, we collect all kinds of information. Some of it is very clinical, like using the ADI and ADOS to make a standard diagnosis and making sure we understand the history of their development. And there are even measures of social skills. but in the final analysis, knowing really what their adaptive skills are, how they function in the environment, is really crucial. And to get observations of them and their functioning at home and in school and in other settings, and to find out how they are very similar in these different settings and how they differ, and try to understand what accounts for those differences. And you know, school is a very special place with a lot of structure, and kids may do much better there than they might do at home or in the community. So we need to think about how we share that then with families. And then the final analysis, really for all children, the function of school is to acquire knowledge and to learn how to adapt in the community, learn to work in groups, do cooperative learning and cooperative playing. And how do we understand the child with ASD's function in those arenas, and what can we do to change and improve that level of adaptive functioning? I want to pause for a moment because we often tend to think about people with ASD as being cognitively impaired. And that used to be the story. In fact, when I was in training, which was, I think, right after Cromwell was the prime minister, the thinking was that 75 to 80% of people with autism had a mental retardation or intellectual disability. Current epidemiologic studies say it's exactly the opposite is true. 75% or 80% have typical cognitive development. But because of their language difficulties, the typical cognitive assessments are highly language dependent, and as a result, children with ASD may perform more poorly because the test is designed for someone who has great language skills. And so it's really important when you assess a child's cognitive functioning to have nonverbal measures of functioning. And there are instruments I've specified here. Make sure you get those done so that you really understand what the child's ability is. And again, the analogy I would use, if you moved to China and had to go to school in China, you know, your language skills might not be so good, and you might seem not pretty dull until you actually acquired the language skills. Doesn't mean you were dull, and it doesn't mean you couldn't learn at a very high level. So getting those language independent cognitive assessments is really critical for planning in school. And the same thing has to do with understanding language. You need to understand the child's language abilities. Now, this is really important because language is the full spectrum of communicative behaviors. It includes speech, but not just speech. It includes gesture, body posture, facial expressions. And if you don't understand all of that, the child's capacity, you not only will not know what they have the ability to comprehend in the language arena, but you may not be able to communicate with them effectively unless you know what tools to use. As I'll come back and tell you, when we use language with children with ASD, we want to use multi-modal language. That is, every kind of tool we can to communicate. All right. So now, if we're going to go design interventions for kids, we should take a look at what things tend to predict outcome in children with ASD. Well, first of all, having good expressive language. And that means being able to communicate, have communicative speech by the age of 5. The earlier it is, the better it is. And having communicative comprehension by the age of 5. The third is what their intellectual capacity is. But this is true for every child. The more typical or better your intellectual skills, the better you can perform in almost everything. What your levels of adaptive functioning are, and then the severity of your autism symptoms. Now, the truth is, if you really look at this list of 5 items, you can't really change intellectual capacity, assuming you have a good measure of it. And the severity of autism, we can modify some of those. But in a school setting or in most settings, the really areas that we work on the most intensively are language, and adaptive functioning, teaching adaptive skills, and some of that includes managing some of the difficult behaviors. So factors that make interventions really work, it requires that we have treatment goals that are developmentally appropriate. Now that means that we have to understand the child's developmental function, but we have to understand the developmental functioning of all children and be able to put the child in a developmental context. So even though a child may be 7, if they're functioning developmentally at the age of 5, then you have to modify your expectations and the tools that you use. On the other hand, if they're 7 and their age is 7, but they're quite mature and functioning at a 9 or 10-year-old level in some domains, then you have to prepare to engage them at those levels. Otherwise, they'll be bored and uninterested. You certainly have to have a treatment setting that's developmentally appropriate, but most schools are. And then try to, all teachers do, make sure that the work has some things that are of interest to the child and not just boring, mundane things. And then certainly the ability of the child to adapt to structures, but also the ability of the structures to adapt to the child makes a big difference. Now, the next few are really critical and really important in schools. First of all, the time engaged in focused activity really is a big predictor of outcomes and makes a giant difference. So keeping a child engaged is really, really important. Secondly, being able to not only tolerate exposure to typically developing peers, but being able to be engaged and involved with them is really important. And to the extent that we can modify situations so that can happen, is great. And then they can learn specific behaviors, even if they're not intuitive or automatic. So for example, early in the care of many patients, I will teach, even low functioning patients, I will teach them, while it may not be intuitive, them to hug or give their parents a kiss. I teach them that very early because they may not know it automatically, but it's so powerfully reinforcing to the parents. And in a classroom setting, it's the same thing, to be able to greet your peers and respond to typical greetings, so that even though the behaviors may be somewhat rote, it just helps them fit into the classroom setting. And then the last point to remember, when we teach a skill to a child, we want to think not just about the acquisition of that skill, but how to generalize it. Of course, schools are the perfect place to do that, because that's exactly what you do. You teach a child to know 1 + 1 is 2, but then you start to have them count things and add them up and measure them and become practical and use them in a broader context. And that's exactly what children with ASD need. Okay, so now I'm going to talk about some of the interventions for autism. But I said it earlier, I'm going to say it again. There are no treatments that are specific for autism spectrum disorder. There are no interventions that are specific for autism spectrum disorder. While we're going to talk about them as being important, they apply to many other neurodevelopmental disorders, and in some cases work very well for typically developing children. Now, that's good news, because it means that many of the interventions you may use for a child with autism will be helpful to other children in the classroom, or most, if not all, of the children in the classroom, which then lowers the level of burden for educators. So there are evidence-based interventions. Most are not syndrome specific. Mostly are driven by symptoms. And almost all of them are multimodal and multidisciplinary. Now, what do I mean by multimodal and multidisciplinary? It means that we use, for example, you may use, when a child is learning to read, we have them read out loud. So you have oral input, and you have and you're reading, and when you're writing, you may have them talk when they're writing, so that they can use multiple tools. Or when we communicate with them, we make sure we use lots of gesture, and we make and use not just the spoken language, but also facial expressions and other gestures. Just think about it yourself. If you go to a movie and it's in a foreign language, you can often understand a great deal of the movie without understanding the language itself, just by looking at people. And even in some movies that are in English, you may not understand what they're about, but you can actually, by watching the faces and so on, you can figure it out. So we rarely cure or make all the symptoms of ASD go away. So that's not our goal in most cases. Our goal is really to achieve optimal function and given a child set of skills. and weaknesses, but also the environmental context in which they work, and trying to give them adaptive skills so they can be as independent in their functioning as possible. Children with ASD need an intervention team. Teachers are a critical part of the team, but it really requires a whole group of other people to be involved. And when you're working with kids in the school, you should have access to some of these people, like speech pathologists, social workers, and you should have information from all the others. And there are many others. This is just one chart that we use. So this is not the work for the solitary. This is a work for a team. So when we think about interventions, what we do is build on existing skills. I told you that before, and we try to work around limits or deficits. We often can't correct them. I mean, if someone's intellectually disabled, we're not likely to be able to change that. And everything has to take place in a developmental context. And the 3B here is really important. We want to use as naturalistic an environment as possible. We don't want to create artificial environments. So having a kid in a regular classroom, and when they have to go do things, they do them in a typical setting with typical kids. To the extent that we can do that, then it provides modeling and structure that is more likely to be effective. And of course, we don't want to do any harm. There are treatments that do harm. Some of the medicines that we use, but there are also behavioral interventions like the wrapping of kids and things like that who just don't want to do it. And a critical part of what I'm going to tell you today is that when you do interventions, you should have measures of your outcome ahead of time and be monitoring whether you're actually achieving your goals. If you're not achieving your goals, don't keep doing it. And I suggest to teachers and schools that if you're going to start a new tool, put a new tool into place, you monitor it every 4 to 6 weeks. And if you're not achieving any goals, stop doing it. Go do something else. Not every good idea works for every child. And so, again, I think the things that we try to focus on primarily are language development and social skill development and managing behavior, the interfering behaviors, language and social deficits. People try to work on others, and that's fine, but I think in a classroom setting, it's really important. And if you look at the last bullet in the last column, experiential deficits, many children with ASD have limited access to the environment. I mentioned the story about the church, but families are often reluctant to take them out on community outings. Schools are reluctant to take them on field trips. And as a result, they're not familiar with many things in the environment, and they lack experience. And that then leads them to not have the knowledge that their peers have and not be able to relate to things in the environment. I admit that it's sometimes difficult to do that, but once the child becomes familiar with things that are common in the environment, going to the playground, going to the movie theater, etc., those kids now become much more able to acquire skills in a variety of settings. So really, when you think about what you're doing, and we're going to talk about this next, we really want to reduce challenging behaviors because they often interfere with everything else on this list. We want to build social communication, and that in young children means skills about play. We want to improve peer interaction so that they can make and keep friends, and I'm going to talk about some specifics of that in a little bit. And we want to give them adaptive skills, how to do hygiene, how to eat properly, how to have homework habits, and even ultimately learn how to interview for a job. And then we want to manage all the emotional problems and comorbidity, make sure that they're properly treated for anxiety, depression, ADHD, and don't have someone tell you, oh, that's just their autism. You know, they can really have mood and anxiety disorders, and those need to be treated. They're also frustrated and sad about when they're aware of the severity of their symptoms and how it limits them. And that's true for most people with ASD. And so you have to manage that sadness and frustration as well. So how early and how often do we do these things? The earlier, the better. If we, in our clinics, we start at 1 We try to get the kids in preschool programs as early as the preschool will take them, because we want to teach them the behaviors of collaborative learning that are so critical in school, and we want to give them the language skills so they can communicate. And then we try to manage their behavior and give them social skills. And the last point on this one, I would say, is that we don't want to forget the families. And so to the extent that it's possible, you want to include families in whatever programming you have so that they can actually practice what you're doing in the classroom when the child is at home. And the more they practice, and the more likely it's going to work in the classroom. All right, so the big elephant in the room, or someone told me in Canada, they say the moose on the table, whatever it is, are behavior problems. And tantrums and aggressive behaviors are by far the most common, and for kids with ASD, that cause injury to themselves or others. And being able to manage these really is crucial. So behavior management is a critical first step. So what can educators do about this? Actually, you can do a lot, and I'll explain to you why. But it depends a lot on what your setting is, the particular child or children with whom you're working, what support services you have. Do you actually have a speech and language pathologist who can come in the classroom? Do you have behavior therapists who can come in the classroom? And do you have community-based doctors? Do you have family support that are willing to help? And what your training experience is. If you have limited in training and experience in the area, it's going to be a lot tougher, and which means that you may need to ask for some training and get people to help you. All right. So there are a whole series of evidence-based group interventions, individual and group-based interventions that can be used in schools. And they work in different ways. They've been studied, and they are showed to be effective. So one you most likely heard about is ABA, Applied Behavior Analysis. Now, behavior analysis is a really nice thing, and I'll tell you how it works. But basically, you identify key behaviors. But the ABA has evolved at this point to have treatments that are really designed to work in naturalistic developmental settings, in schools, for example. So one is called pivotal response treatment, PRT. Early Start Denver model is an early intervention program, and these have strong evidence and work very effectively. There's also a program called Teach, which provides something called structured teaching, which is a set of tools that teach you how to organize your classroom so that you have the appropriate materials at the appropriate time, and be able to put away materials so that they're not distracting, and allow the child to acquire skills that they need. Structured teaching, by the way, works really well for lots of kids, not just kids with ASD. And in fact, many teachers I know who just do it for everybody. And then there's some groups using peers, which is again a structured program that includes kids with ASD, but it also includes typically developing kids, and it works on developing reciprocal social skills. So all these tools that are available, many of them are not terribly expensive or require some training, but once they're implemented, they can make a big difference for the kids with ASD and for your classroom and your classroom structure. So it works very effectively. So within behavior therapy, we talked briefly about ABA, and then there's discrete trial training. One of the forms of that was something called the Lovaas model, which was the earliest of the ABA treatments. And the problem with Lovaas model is that it took place at a table, either at home or in the classroom, and wasn't in a naturalistic setting. So they had the child just repeating by rote, training them to do particular skills and behaviors, but it didn't really help very much when you came time to generalize it. And so that becomes a problem. And then I would just remind you that there are also parent training programs as well. Now, why naturalistic interventions? And the PRT was started by a couple of psychologists named Kegel. it really allows for generalization, and then that means that the behavior change is maintained, and so the long-term effects are better. Most of the behaviors that you're teaching are socially valid. They're relevant to the child's interactions with peers and with their family. They're highly motivating because they're things that are in the environment that can be readily available, and they have demonstrated to improve functioning even in very young children. And by the way, even when applied to kids who don't have ASD but have behavior problems or emotional problems, they appear to be effective as well. So how do you really, at the end of the day, how do you really do behavioral treatments? Well, it's pretty simple, actually. The first thing you do is you identify target behaviors. So if you're in a classroom, you have to really identify the behaviors you're going to change. And this is true for both kids with ASD and non-ASD. That means it takes a bit of time to describe them and measure them. What do I mean by describe them and measure them? It means that you have to say, this is exactly what the problematic behavior is. They throw things, but not just things. They only throw pencils or crayons, or they only throw erasers, whatever they throw, and the direction in which they throw them, and the frequency which they throw them, and being able to count how often and where they do them. You have to have a very precise description of the behavior. And then it's not just the behavior itself, but the behaviors often don't come out of nowhere. There's some things that happen before. And so knowing what comes before the behavior is very helpful, because you may, instead of trying to modify the behavior, you may try to modify what comes before, or what we call the antecedent. So if, for example, before a child throws something, he squeals or stomps his feet, or he gives some other cue, that knowing that as part of the description of behavior actually gives you a target that then helps you prevent the behavior and helps the child function better. The next part is you have to know what good reinforcers are. That is, what are the rewards you can give the child for engaging in a positive behavior or not engaging in a negative behavior? Positive reinforcers, that is, things that make the child feel better, are good. Negative reinforcers, like punishment, are not as good. And the reason they're not as good is because they're not as enduring in their effect. The effect doesn't last as long for a negative behavior as it does for positive behavior. So once you identify the behavior, you describe it carefully, you describe the reinforcers, and then you set up a plan where you're going to reinforce the behavior, either when it occurs positively, a positive behavior occurs, or when a negative behavior occurs. And you initiate a trial. You're going to say, okay, I'm going to practice this in little steps. I'm going to take the child, and for 5 minutes, I'm going to try to work on this behavior, but I'm going to do it 5 minutes twice a day and see if I can start to change the behavior. And you have to be able to measure the change using the same measures used when you were counting the behavior. And then if it's getting better, then you keep doing it. If it's not getting better, then change the program so that you can get the level of improvement that you like. And then you just keep doing this over and over and over again. And eventually you'll shape the behaviors. It's actually not, it's not always easy, but it's not really complicated. It's relatively straightforward and simple. So so not only do you describe one behavior, but you make a list of behaviors and have a priority list. Take care of one behavior, then you start the next one. And if you share your behavioral plan with parents so they can do it at home, then it'll even work more quickly. So this is the basics of behavioral intervention. Speech and language functioning and therapy. I mentioned multimodal communication. I think one of the things that people tend to be shy about doing in school settings is to demand communication. So if you have a child in your class, helping him to use your words or make a sign or any noise that'll be communicative, I'm happy to hear that. And start with communication, expecting to get gesture, then a vocalization that may be meaningful. Then before you know it, you can build that into words, and then words into phrases, phrases into sentences, sentences into paragraphs, and then it creates the framework for reciprocal communication. And do not underestimate the value of exposure to natural language. So even if the child has difficulty comprehending or expressing, having them in social settings where they can see and hear social transactions take place, it creates an opportunity for modeling. And that's in school and communities, with siblings, with peers, and God forbid, even using television or movies, videos, video games. If they're highly language intensive, then that can be really helpful in getting the children to start to acquire and use language. It may not be the most perfect language, or it may not be entirely socially appropriate at first, but once they start using that language, both nonverbal and verbal language, now you have something to build from, and that becomes really important. So use the language that's there. Don't create. You don't have to create new things. But when you're having trouble, or a child really can't speak and is having trouble with gesture, there are all other tools that you can use. Some of you may be familiar with picture exchange programs. The child has a set of pictures on a ring or available to them, and if they want something, they pass you a picture and say, that they want candy, or they want cereal, or whatever, want a drink. Creating that vocabulary takes a bit of time. Usually a speech pathologist helps do it, but it can be very helpful, particularly when a child gets stuck and they can't speak. For some children, using sign language may be appropriate, but with both PECs and with sign language, we try to encourage vocalization. And then there are computer programs that'll speak for a child. You can type, they can learn to type something, and then the computer will speak for them. It's really not uncommon. And I have a number of patients who can't speak, but they actually have average or above average intelligence, and they type things in the computer talks for them, and they actually manage quite nicely in school. So they're difficult to use, but for the classroom, but they can be quite powerful for the child. Now, when we think about educational programming itself, I think it's really important to think about the classroom setting. And we clearly prefer inclusion settings where kids are mixed with typically developing children. But there are some places where they have all the children with developmental disorders in a self-contained environment. It's clearly not optimal. It's far better if you have to have some services delivered outside the classroom to minimize those. It's better to have the speech pathologist or the physical therapist or the occupational therapist come into the classroom and work with the child in the midst of what they're doing in the class and with their peers. Now, some people fear that worry about the fact that children may seem labeled or targeted or subject to stigma because of this, and that really isn't the case. And I'm going to give you some examples of that. And the other thing let me back up. Don't underestimate the value of rote learning. Just learning something so that you know it automatically, like I told you about hugging and kissing parents, but also greetings and other kinds of things. That's a good start. Then taking that rote learning and generalizing it can be quite a bit easier if you don't have the skill at all. And you can do that with speech, language, social skills, and behavior. And there are structured programs for training people in social skills. And many of these social skills programs are extremely helpful, not only to children with ASD, but also with typically developing children. Kids with ADHD who often have social problems. I just listed some, but there are dozens of them. And being able to implement them in your classroom it was quite useful. But don't underestimate the value of group activities in younger grades, circle time, and older grades, group projects around tables, and helping the children with ASD be integrated with the kids who are typically developing. And I keep promising I'm going to come back to that with a particular program in a moment. And then parent training is quite crucial, oftentimes not really in the purview of teachers, but making sure that parents get into training programs that teach them the skills of building structures at home and being able to replicate the things that you're doing at school and doing other things that will supplement what you're doing at school. Psychotherapy in general doesn't really apply to schools in most cases, but I would comment that I think there's some often great value in schools to do things like mindfulness and relaxation therapy or even yoga to reduce tension. And this applies to all children, but can be especially helpful for children with ASD because you can help them be mindful or relax and get them in a position to start over again when they become disorganized or having frustrated. But that would apply for all children. And in fact, I'm working in a school now, and we've actually started providing mindfulness training for teachers because it helps teachers get reorganized and settled. I know that may seem silly to some of you, but actually, it's the impact by doing mindfulness training for the teachers. It's actually changed the environment in the school more than all the training we did with the kids. But anyway. There are a lot of other treatments that people suggest, like facilitated communication. It does not work. Don't waste your time on it. Certain kinds of medicine, sensory diets, no evidence that that works. So you're focusing on these basic things of language, behavior, and social skills be far more useful and far more effective use of your time. I want to mention, and I'm going to do this very, very fast, that some people want to use medicines and they are very effective, but most of them are not specific to autism themselves. So, so what can we accomplish with pharmacology? We can treat specific behaviors and symptoms. We need them described and we have to be able to measure them, just like you can do in a behavioral program. This would really augment the behavioral treatment program. And the goal is to decrease the problems that interfere with other interventions. And we don't want to cause any harm. There are a couple of things to remember. All medications have side effects, and this can be a special problem for ASD because the kids may not be as able to report these side effects. So we need to help with schools and others to monitor them. And just because a small amount of medication works doesn't mean that a lot will work better. And this is also a problem with people with ASD because they often can't tell us everything that's happening to them. So for the repetitive behaviors like stimming and habits and tics, there are medicines that we use for that. They're called SSRIs. Drugs like Prozac and Zoloft are quite effective in this for some children. For aggressive and irritable behavior, we can use medicines called neuroleptics. The ones we most commonly use these days are drugs like Abilify and Risperidone or Risperdal. They have different names in different countries, so I put the generic names there for you. But so they seem to be pretty effective. For people with ADHD and attentional problems, using the stimulants, we've been using stimulants now for almost 90 years. There are over 600 controlled trials. They're safe and effective, and they really work. And it doesn't matter if you have ADHD, they work very effectively. Kids with autism and attentional problems, they do very well too. For mood problems, just like the rest of the world, mood stabilizers, which look like antidepressants, or the SSRIs, antidepressants, are helpful for stabilizing mood. And then there are anti-anxiety medicines that are available. For the most part, they don't work as well, but we use SSRIs. We never use drugs like Valium and Librium like we do in adults. They have their own special problems. And then some people suggest all kinds of things that we should be doing with kids. If your kids are getting them, I would, be careful. So vitamin therapy doesn't seem to work. Dietary supplements doesn't seem to work. Restricting sugar or other things, food dyes doesn't seem to change behavior. And then who knows? There are all kinds of wacky things that people do. So most of these things have been studied and are just not effective. All right, so let's get practical before I wrap up here. What are ideas for change in the classroom? Well, first of all, the first thing to think about is the classroom setup and structure and how space is organized and what the environment is like. For children with ASD, but the truth is for most children, overly stimulating environments are not particularly helpful. That is, if there's a lot of noise, there's a lot of color, there's a lot of movement, there's just a lot of chaos. It may not look like chaos, but it can to the kids. And so thinking about how you organize your space so that children have discrete places to go, that they have predictable places where their things are kept and belong, and they know where to return them, they know where to find them, and you can use the space to teach them skills. Somehow in modern world, we think that structure is a bad thing. In fact, the more structure is, the better it is for particularly young children. And so having real schedules that children can really understand and daily routines that are quite predictable. For children with ASD, giving them copies of their schedules on their desk or on their table makes it a lot easier for them. And then even helping them check off as things happen. And when they look like they're lost or confused, ask them to look at their schedules and tell you what's going to happen next or what's happening now, so that they can learn to follow these routines and use the routines as a foundation for learning rather than as a obstacle for them to manage. Schedules and routines are good. And then the last thing that you need to set up in classrooms is group and individual activities, understanding that not everything is taught well in a group, and some things need individual skills, and making those decisions and creating the structures to do that. Number 2 is pre-learning. I'm not sure if you've ever heard of this, but pre-learning is what I do with most of my kids is I have the teacher give the parents the books and the assignments at home, and the night before, they have the parents review what the child is going to do in class the next day. And that way, when the child comes into class, it's not foreign to them. They even may know enough to be able to raise their hand and answer questions, but more importantly, they're not just flying blind. They've had a chance to learn the vocabulary, learn the topic, and be able to participate more fully. And it makes it much easier for the teacher because now they're not dealing with a child who has no idea what's happening. The child has at least been forewarned about what they're going to have to deal with. I think it's also sometimes quite useful to have some kind of behavioral system operating in a classroom. It may not be your style, but think about it for a minute. If you have a structured reward system in the class, whether it's using points or some other measure, but for which kids are rewarded on a regular basis for participating in the activities, accomplishing tasks, completing tasks, or engaging with each other, or completing short-term objectives, then you're much more likely to have a structure that the kids can work in and have reinforcers. Language and support and focus is always crucial in the classroom for children with ASD. Focusing on language and having a language plan for each child with autism. Then there's the matter of peer buddies. Now, I haven't mentioned this until now, but children with ASD can often really benefit from having peers who can work with them. Children who have been, children are quite intuitive. Typically developing children are often quite intuitive. And if you can explain to them what the child with autism's difficulties were and ask them to help you, they often will become very, very valuable supporters of the child and be able to help the child when they're lost or confused. And what we try to do is in every classroom have a couple of kids who we've trained to help out the child, and we call them peer buddies. The child with autism knows that they have a peer buddy. The peer buddies often engage with the kids outside of school and help them. And I've seen this work so effectively. And the outcome, the positive outcome for the child with autism is enormous. The outcome for the kids who have been able to help their peer may be even better. And I've followed some of these peer buddies out into adulthood, and I can tell you many of them talk about their experience as being a peer buddy as one of the transformative points in their lives. Then of course, coordinating care is really important. The tendency of teachers to be in a classroom by themselves is really a problem. Their kids are in other classrooms, coordinate what you're doing with the other classrooms and with activities outside of school. That parents and coaches and other teachers may have clever ideas that you wouldn't think of, and you may have clever ideas that they don't think of, and being able to share them means that you're going to create a much more successful program. So coordinating between home, school, and community is really a good idea. And then finally, and people never talk about this, make time for fun. While it's always good to work hard and learn things, sometimes it's good just to be silly and have a good time. That's really reinforcing and makes school a happier place and makes a better outcome for kids with ASD. So, in conclusion, environmental interventions are central to the treatment of autism, include speech and language therapy, behavioral treatments, and educational interventions, and community-based activities, all intertwined with one another and coordinated with one another. That's what makes an outcome. You notice I don't have medicine on here. I don't have psychotherapy on here. I don't have any kind of complex systems of care. Just doing these basic things will make a huge difference. And most children with ASD and ADHD and other neurodevelopmental disorders get better over time. So, we should just take advantage of that. In fact, our goal is to improve the rate at which they acquire skills and get better and not interfere with how they're doing. And we will find many opportunities for success. So it takes a lot of planning, takes a lot of coordination, takes a team, but it takes also a very positive outlook and ability to share in the individual's accomplishments, joys, and happiness. And there will be many for you as a teacher, but also for the kids and their families. So at that point, I will stop and be happy to answer your questions.
Thanks, Bennett, as always, for the wonderful, wonderful presentation. I just group a few sort of sets of questions for you that appeared in the chat. So one is questions around sort of almost like forcing neurotypical behaviors, atypical children, and that it could actually be even abusive. Do you have a view on that?
Sure. I don't think about it that way. I think, first of all, forcing is not a term I tend to like. I certainly can encourage, shape, reinforce adaptive behavior. It's not neurotypical behavior, it's adaptive behavior. So what is it that this child needs to adapt to the environment in which they live? So, some are simple and straightforward. Pooping in your pants doesn't really help you out when you're in a peer group. So teaching someone to use a toilet is, I think, a useful thing. Is it neurotypical behavior? Who cares? Just pooping in your pants is not good. Spitting at people, hitting people, those things are just not, they don't help you adapt in the world in which you want to live. Do you have to give up every one of your little peculiar behaviors? No. But to the extent that they interfere with being involved with other people or learning, then you have to learn to contain them or move them into other environments. So, so that, you can go to your room if you want to spin and flap. That's okay, but you can't do it here because it's just not appropriate and interferes with your adaptation in that setting and environment. So I don't want to get into the argument about what's neurotypical and what's not neurotypical. I want to think about what helps this child function in the environment in which they live.
Okay. And the second sort of group of questions are around peer buddies, and it sounds like it's something that resonates with people. Are you aware of any specific sort of trainings for this kind of thing?
There are training programs that, and I can find them for you, but actually, I find that most teachers are really good at doing this once they get permission to do it. And it requires, or in a school, you sit down and talk with parents of typically developing kids, and you say, this is an opportunity for your child to learn to be generous and helpful to others. And the kids, you'd never have trouble finding kids to volunteer to do this, ever. Just people start to worry, well, are they going to become autistic? No, they're not. Autism isn't contagious. Is it going to take away from their classroom experience? No, it will not. It'll actually improve it. And so it's just a matter of, and then how you go about doing it really depends on where you live and the sort of the standards in your community. I mean, I could tell stories that would make you cry, really, about the amazing things that kids did, and how they sustained them long after they were in the classroom. So I've had kids who are peer buddies who started in grade school and stayed with their peer or buddy. And that is, the typically developing kids stayed with their peer buddy all the way through high school, took them out on dates with them, took them to football games, or took them to movies. And when they were no longer required to do so, no required, they were never required, but no longer part of the structured school, they did it spontaneously. And I think that you'll find that giving typically developing children an opportunity to do this and showing them how to do it, then they naturally figure out what to do. You don't have to teach them really very much. You just tell them this is what we're going to do and get them started, and they'll figure it out all by themselves. And by the way, they play a critical role in stopping bullying too, because what they do is when their peers start to tease or bully, they stand up and they say, no, you can't do this. And they interfere with it, and it reduces bullying as well. It's an amazing experience.
Thanks, Bennett. Then there are questions around rewards. A colleague is saying that it is very difficult sometimes to find the appropriate reward for the child. Then there is a suggestion sometimes the special interest could be that reward. Do you have a view on rewards in general, and also the use of special interest as a reward?
Well, when you first start with some children, it is true. You're correct. It's very difficult to find a reward that is meaningful. In fact, the most difficult children are the ones who are sort of passive, very, very passive, and don't even move. And so for those kids, they're unusual. It requires really a special set of behavioral activation and motivation activities that really require a skilled psychologist to put into place. But you have to search for rewards sometimes. And the other problem is that there may be very few and they wear out. So, but if you do a careful job of observing a child, you'll find things that just seem to please them or make them happy, and you just start trying them. And talk to parents, talk to others who have been with the child. Is there anything that this child likes? And you'll take anything, whether it's playing a video game or using a mobile phone to do something silly, even if it's a bit repetitive. You got to start somewhere. And then what you want to do is move away from reinforcers that you think are not helpful or useful. But for most kids, I mean, edibles and other things are often pretty easy to come up with. But there are a small group that it's a real challenge, in which case then you may need help doing that.
Yes, there's a comment that a colleague has some children who struggle with anything that has time constraints, and focusing on the time element and not being able to then show their true ability. I suppose it's just a comment. I don't think there's
I'm happy to comment on that. I have trouble with everything that has time constraints. I mean, welcome to the world. And so I'm not actually making fun of you at all. It is one of the critical things for children to learn, that certain thing has to be done in certain periods of time. It's probably not where you want to start, though. So if a child is having trouble doing mathematical operations, giving them a time limit isn't the goal. The goal is to get them to get the mathematical operation done, or to read, or whatever the task is, put their books away, get them to do it first, and then start putting time frames on it, and start really wide time frames. So you have 10 minutes to get your books put away before you leave school. Then after a few days, you might change it to 9 minutes and 8 minutes and 7 minutes, and constrain it. Or if you want them to pay attention longer, then you expand it. But adding time to the management of a skill, that requires just practice and gradual shifting, and kids will learn it. I mean, just think about how you teach your kids to stay in bed at night. I mean, it's the same thing.
But I guess I only have the time for final question, which is, I think you mentioned quite a few assessment tools to understand the strengths and deficits and problems. Is there anything in particular that you would just recommend as the most useful tool for assessment?
Well, while it's very cumbersome, I think the Vineland is really useful to get the Vineland done on children early, so you get a real sense of what their adaptive behavioral capacities are, is really useful. If you can't do that, then using things like the SDQ or something that gives you some sense of what the kid's strengths and weaknesses are would be a useful tool. I don't know what is commonly available in your community, so probably best ask one of the psychologists. You have a wonderful team. I'm guessing a number of them will have ideas. But you need one that is not just about what's wrong, but what they can do well.
And then all that remains for me to say is to thank you one more time greatly from everybody here. It was a wonderful, wonderful talk. I certainly learned a lot from it. I hope our colleagues have done as well. And if you'd like to read the thank you messages, they're just coming now in the chat.
Well, I'm actually honored that you would invite me and allow me to participate. So it's been my privilege.
It's been a great pleasure and privilege. Thank you very much, Bennett, and I hope to speak to you soon.
Bye-bye, everybody.